Hello, and welcome to another session of our digital slide review and sign out. I'm Dr. Lewis Hassel, and our program is part of the Digital Anatomic Pathology Academy. Our case today comes from the files at the University of Oklahoma Health Sciences Center, where I am located. Our case today comes from the realm of bone pathology again. The patient is a middle-aged man who has several month history of lower leg pain. And on evaluation, he's found to have a destructive lesion on radiography. So here's some representative plain films and MRI. And we can see that here in the mid shaft of the tibia, he has sort of a teardrop shaped lytic lesion that may have a bit of a soft tissue extension and certainly is destroying the cortex. Although the margins are fairly sharp in some areas, the cortical destruction is concerning, and we can see here on the MRI that we have both an intramedullary and an extramedullary component along with this destructive cortical change that we see here. And it's sort of an intermediate density. It's not the density of fat nor of skeletal muscle. So proceeding with biopsy, this section of course, raises the very same differential that we discussed in a very recent case of lymphoma of bone. But again, a midshaft destructive lesion, an adult. We're going to be thinking here about sarcoma, metastatic carcinoma, lymphoma, or infection. The patient had been otherwise well, and there was no recent history of neoplasia. So we were thinking that this might be a sarcoma. Or possibly infection, of course. Frozen section evaluation produced this nice fragment of tissue, and we can see it's fairly cellular, somewhat bluish purple in color. This is a good quality frozen section. And we can see some nesting of the cells, a little bit of cracking and so forth. Not much in the way of glandular formation. It doesn't seem to be making keratin pearls or anything of that sort. We have a little bit of necrotic destructive tissue in between. And the cells have a bit of a plasmacytoid appearance, although there's a fair degree of pleomorphism with this. So they're not really classic cytoplasmic or plasmacytoid cells. And look here, we've got a few cells that have this nice inclusion in the nucleus. So this raised the history of melanoma as a possibility. And on further questioning, the surgeon volunteered that the patient did have a very remote history of melanoma. He'd had a very thin melanoma excised almost 40 years ago, and then had about 20 years ago had an axillary, nodal resection that had also uncovered melanoma, draining that particular site. Well, 20 years is a long time, of course, but that seemed like a very plausible possibility given the morphology. So here's a representative permanent section of this lesion. And again, we see this similar sort of appearance, a very diffuse pattern, some areas of necrosis, no real epithelial type architecture, a little bit of clear cell architecture pattern, a defined, fairly sharp border as we indicated. And then on high magnification, we can see that, again, these cells have this sort of amphiphilic cytoplasm, a little bit of eccentric nuclear placement, again, slightly plasmacytoid, and pretty prominent nucleoli and variability. Some mitotic figures are present in and around these areas. Looking a little further, we see this sort of wispiness to the cytoplasm in some areas, sort of almost fibrillar character. And then here we can see a few more of the coarse chromatin pattern, plasmacytoid changes, And in a few areas, we saw again these sort of nuclear inclusions. I don't know if I can find one here right off. Maybe a little bit of one there. And some degree of prominent central nucleoli mitotic figures as noted here. So again, this still looks like it may well be melanoma, but other lesions had to be considered, and so immunohistochemistry was undertaken. So a representative section here using our red chromogen, and we can see that it's nicely positive here. This is labeling using MART1, melon A, and we use the red chromogen so that we aren't confused by background melon pigment, which we didn't really see, but we didn't want to have that confound the picture. So our diagnosis on this, based on the immunohistochemistry and the morphology, is a delayed recurrence of malignant melanoma. So this is a very much an outlier, but these are reported and are not unheard of by any means. It has come to fall into the category of what's termed tumor dormancy, and including melanoma, there are several others. This is defined as a stage of cancer progression in which the residual disease is present but remains asymptomatic without progression. On study of these, one large study found that, in fact, these late recurrence patients tended to be more frequently younger, female, have thin primary lesions that were not involving head or neck sites. They were not ulcerated and generally did not have regional nodal metastases. Now, in this case, he did have a delayed regional metastasis, but this highlights the fact that distant recurrences are, in fact, what we tend to find in these delayed circumstances. Now, what's the basis of this? Well, one study has found that there are quite high rates of circulating tumor cells in the blood that can be found in both stage 1 and stage 2 patients at diagnosis. So we know that melanoma can be considered a systemic disease from a very early stage. But what triggers the dormancy or the later recurrence remains to be determined. It seems to be most likely postulated that it's a combination of both host and tumor factors. But we know that melanoma is one of those tumors that's notorious for immunologic control, and that's, of course, the foundation for some of the current targeted therapies in this situation. Interestingly, and this is, I think, what is perhaps most intriguing, is that these patients who have a late recurrence actually have better overall survival than patients who have earlier recurrence. And that's not just because they go a long time before the recurrence appears. This is disease-free survival. And so that is a very interesting thing, which suggests, again, that some host factors are involved in controlling the disease. So that's our case for today, metastatic melanoma in a very delayed recurrence. We hope that you enjoyed that, and that if you liked it, you'll maybe share with us one of your experiences with the longest disease-free survival with a late recurrence that you've encountered, and what kind of cancer. Also, please subscribe so that you'll catch releases of future videos on our channel. And of course, we always welcome your questions or comments, suggestions for things you'd like to see us produce. So until next time, thank you so much for joining us today.